Hi nurses, Navkiran this side. So today we are going to discuss about a very important topic which is not only important from your NCLEX RN point of view, but in every entrance exam you will find this topic. Yes, I'm talking about shock. And today in this video we are going to discuss about what shock is actually, what are its types, what is pathophysiology, what could be the sign and symptoms, and what could be the nursing management. So let us start with the topic. See, shock is a kind of condition which occurs due to hemodynamic instability. Basically, what would happen? There will be decreased circulatory blood volume. Because of that, there will be decreased cardiac output. Various types of shocks could result in various type of manifestations, but usually there will be hypotension, multi-organ failure because of decreased perfusion, and the organs are not getting enough blood supply. So there could be various types of shock. Number one is hypovolemic shock. The second one is cardiogenic shock. Third one is anaphylactic shock. The fourth one could be the septic shock, and the last one could be neurogenic shock. Okay, so let us discuss about hypovolemic shock at first. So talking about hypovolemic shock, the as the name is indicating, hypovolemic shock results from hypovolemia. Well, hypovolemia could occur due to hemorrhage, which could be internal or external. It could also occur due to GI bleeding, due to trauma, due to any sort of volume loss because of dehydration. If your patient is suffering from severe vomiting or diarrhea, because of these things also hypovolemia could occur. And this results in shock when all these conditions are occurring at a critical scale. Okay, I must say this. And then third spacing could be the reason. Now, what is third spacing? Third spacing is when a lot of fluid accumulates in a body space where it is not required. For example, ascites. For example, pleural effusion. In these conditions, what would happen? The fluid is present in a cavity, but it is present in more amount, more than required. And this will not come into any intake and output. That kind of condition is called as third spacing. And also in third spacing, the fluid could also shift to the interstitial spaces due to conditions like burns, severe trauma or sepsis, etc. So this is called as third spacing, basically fluid loss from your circulatory blood volume. So all these three reasons like hemorrhage, dehydration, third spacing could lead to hypovolemic shock. Let's talk about pathophysiology. When talking about pathophysiology, we will start from decreased venous return to the heart. If there is decreased venous return to the heart would also give out less blood. That means the output would also be less. When the output is less, obviously the organs are not getting enough blood supply and hence not enough oxygen, and multi-system failure will start occurring. And in response to the decreased perfusion, some of the compensatory mechanisms would start working in our body, and they will lead to tachycardia, vasoconstriction, because your body is attempting to maintain the blood pressure, because hypotension is resulting from decreased venous return and then decreased cardiac output. In order to maintain this thing, the body is trying to, the compensatory mechanisms are trying to maintain blood pressure. But if this condition will go a long way, we are not correcting it with the help of fluid resuscitation by giving colloids or crystalloids. Eventually your compensatory mechanism will start working other way. There will be massive vasodilation and there will be severe hypotension, which are the hallmark of shock. Now, sign and symptoms. In your exam, if you are getting the question like what is the first sign of shock, then altered mental status is the answer. So basically there are 5 primary signs of the shock. One is altered mental status, second one is decreased BP, hypotension, then we have tachycardia, then we have decreased urine output and cool and clammy skin. The skin will be pale or ash color and it will be very cool to touch. So all these things indicate shock. If we talk about nursing management, assessment is a key. As I have already told you that the blood pressure will be lower than the normal values. So first of all, we'll have to assess the vital signs of the client. The respiratory rate could be fast. The patient could be suffering from tachypnea because of the lack of oxygen in the tissues. The person will be having less BP, more than less than normal. Then the pulse rate would be high. There will be tachycardia and the pulse will be very weak and feeble. Very difficult to find a pulse. And also you have to continuously monitor the level of consciousness, the skin color, temperature of the skin and even the moisture of the skin. As I have already told you, the skin will be cool to touch and it will be pale or ash color. We have to measure the urine output as well. The urine output would be less than 30 ml per hour, and that indicates that the kidneys are not getting enough blood to filter out the urine out of them. And then what we could do, assessment is done. Fluid resuscitation is the first and the primary step that you can do to revive this patient of the shock. Then you have to administer IV fluids like crystalloids. NS is the most important fluid, that is normal saline, which we start giving to this client. The nurses should note that in this condition, bilaterally you have to insert 16 gauge cannula, and in one side the fluid resuscitation might be going on, and if there is decreased blood volume or hemorrhage is occurring somewhere, we have to do the blood transfusion as well. For that you have to insert another cannula, right? So bilateral cannula, that is 16 gauge, should be inserted, and the fluid should go at the fast rate. In addition to this, we have to address the underlying cause as well. If the cause of shock is hypovolemia, we have to control the bleeding as well. We have to replace the fluids and electrolytes which are lost due to dehydration, and sometimes surgery could also be done in order to control the bleeding which is happening inside the body, internal hemorrhage. And you should also start the oxygen therapy, because tachypnea is happening, your tissues are getting less blood supply, so oxygen therapy could also be initiated. And we have to prevent the complications as well. Sometime what will happen, I want to highlight one point here. Whenever you are doing fluid resuscitation, doesn't matter you are doing in a patient of burns or of hypovolemia, we have to note down the urine output per hour. If the urine output has already reached 50 ml per hour, then we should decrease the amount of fluid that we are giving, or we should inform the doctor. Why? Because the more amount of fluid that you are giving now to the patient is going into circulation, right? So this will cause hypervolemia. So this could be one of the complication of the treatment that you are doing in the patient of shock. So all these things could be monitored. Now we will move forward to the next type of shock, which is called as septic shock. So basically septic shock is a kind of shock which happens due to overwhelming infection, which actually initiates a series of inflammatory events in our body, and that occurs due to dysregulated immune response. Basically the causes could be bacterial, viral, parasitic or fungal infections, or it could be caused due to the toxins which are released by these organisms. So talking about the pathophysiology, first of all, these bacteria and viruses, they will release the toxins. These toxins which will trigger our immune system. Our immune system, which is working to protect our body from these microorganisms, will release certain chemicals like cytokines and other inflammatory mediators, which will initiate the series of events which will lead to widespread vasodilation, and capillary permeability will be increased, and certain coagulation pathways will be activated. So basically three things are happening. Vasodilation is happening, which will decrease the blood pressure. Coagulation cascade is activated abnormally, which will lead to disseminated intravascular coagulopathy, and also due to increased capillary permeability, the more and more fluids and proteins will be leaked into the tissues, hence it will cause body systemic edema in the body, which is also called as anasarca. Now vasodilation and hypotension will cause the signs of shock, and even microvascular dysfunction will lead to the formation of small clots in the small circulatory system. And DIC is a kind of condition in which there will be the clot formation as well as there will be bleeding happening in the body. Now how this happens? When there is an inflammatory response that is going systemically in your body, it will result in the activation of coagulation cascade, which will block the small blood vessels. The body will send a lot of coagulation factors in one place, and at the other place the small blood vessels will start bursting, or the bleeding will happen because of the lack of coagulation factors or clotting factors. And then the sign and symptoms are same as any other type of shock, but they could vary slightly. For example, the fever would be there due to sepsis, but in this condition the patient is presenting with the low grade fever, and also there could be hypothermia. Now why this is happening, I will let you know when we will be talking about it in detail. Hypotension would be there, tachycardia, fever, altered mental status, hyperventilation could be there, as I have already told you. Tachynia could be there because of the lack of oxygen supply. Warm and flushed skin could be there. See, this is the difference. One is fever, the second one is a warm and flushed skin in septic shock. When we were talking about the hypovolemic shock, I had told you that the skin would be pale or cool to touch. Here, the skin would be warm and flushed, but that is in the initial stages of the septic shock. In the late stages, when the vasodilation will be kind of massive, in that case the skin might become cool and pale to look. And then if we talk about the nursing management, early recognition is very important. As a nurse, we have to identify the signs of septic shock and we should initiate the treatment without delay. We have to implement the standardized protocols which are there according to your agency policy to control the sepsis. For example, we have to initiate the antibiotic therapy, we have to initiate the fluid resuscitation therapy, and with any type of shock you have to start the infusion of normal saline immediately. One thing is very important to know in septic shock, and that is vasopressor therapy. In this, the massive vasodilation is occurring, which is causing hypotension. So in the case of septic shock, you give injection vasopressin. Yes, that injection is given. Also norepinephrine is given, and we have to titrate the vasopressors on the basis of like hemodynamic monitoring, which we are doing regularly, and we have to control the source of infection as well. The source of infection could be an abscess which need to be drained, or it could be the case of peritonitis, it could be the case of lung abscess. So we have to control the source so that we could control the source of infection which is sending the infection into the blood. Then there is a supportive care. There are certain complications which are occurring due to septic shock, for example respiratory failure, renal failure, or DIC. We have to address that, and also we have to continuously monitor the vital signs of the client, oxygen saturation, and the laboratory values, for example the blood gases, and also the clotting studies. And also we have to continuously monitor our client for hemodynamic stability or instability via central venous pressure monitoring. So all these things are done to control or to treat the septic shock. Now we are moving forward to anaphylactic shock. Now we will talk about anaphylactic shock. As the name is indicating, anaphylaxis is related to some allergic reaction. Well, this allergic reaction is potentially life-threatening allergic reaction, and this would result in shock because of this systemic allergic reaction, the massive vasodilation and increased capillary permeability and bronchoconstriction would happen. Now the causes could be various allergens. As we know, some of the people are allergic to certain kind of foods like nuts, shellfish, and even eggs, and some of the medications like antibiotics, NSAIDs, or contrast media. And also some of the people are allergic to insect stings like bee venom, wasp sting, or some of the people are allergic to latex as well, or certain environmental factors like pollen or animal dander. So all these things could lead to anaphylaxis. Then there are some other factors like if you eat food before exercise, so exercise induced factors could also be there. Talking about pathophysiology, whenever our body is being introduced to some kind of antigen to which it is allergic, it will trigger the release of IgE, which is a kind of antibody which is produced against that particular type of antigen. On the first exposure, your body will not react at all. But in the case of re-exposure, your body is already ready with IgE to attack on that particular antigen. Well, this will trigger a massive immune response. And because of that, there will be release of mediators. Let us suppose I come in contact with an antigen, my body will start producing IgE against those antigen. There will be immune response that will be triggered in my body, and it will result in the release of some of the inflammatory mediators like histamine, leukotrienes, and prostaglandins that will cause series of events in my body. For example, they will increase the capillary permeability, they could cause massive vasodilation, and they could also cause bronchoconstriction. For that reason, like the patient will not be able to breathe properly, there will be smooth muscle contraction, and these are the manifestations of anaphylaxis. Now there will be hypotension and shock. Why shock is happening, why hypotension is happening? Vasodilation and increased capillary permeability will lead to shock, and there will be swelling all over the body, especially around the eyes, on the face, because of increased capillary permeability. The fluid is pooling out of the blood vessels into the tissues. Now respiratory symptoms would also be there, in which there will be wheezing, dyspnea, stridor, coughing, there will be chest tightness, respiratory symptoms along with the cutaneous symptoms like itching, urticaria, angioedema, flushing of the skin would be there. GI systems, system manifestations like abdominal pain, nausea, vomiting, diarrhea, and even cardiovascular system, like there will be tachycardia, that means increased pulse rate, and the pulse rate again will be very weak and feeble, and also there will be hypotension. So all these symptoms are happening, and sometimes if anaphylaxis is very severe, then neurological signs will also be seen, like dizziness, lightheadedness, syncope, altered mental status could also be there. So talking about nursing management, the first thing is assessment. We have to recognize the sign and symptoms of anaphylaxis. We have to check the respiratory rate. We have to check the oxygen saturation of the patient. And also we have to obtain a thorough history of allergies, like to what things this particular patient is allergic to. And also we have to do airway management. See, whenever we are talking about anaphylaxis, respiratory system involvement will always take the priority, and in management, airway will always take the priority. So we have to ensure that the patient is having a patent airway. For that, you have to maintain upright position. We have to monitor the oxygen saturation and have to initiate the oxygen therapy. Well, oxygen therapy could be given via nasal cannula, and it should be high flow oxygen therapy. It could also be given through various oxygen delivering masks, and also we have to be prepared for advanced airway support. If these methods are not relieving the airway obstruction, or the patient is not able to maintain a required oxygen saturation, we can insert an endotracheal tube as well. So we have to assist the doctor in that. Then epinephrine administration should be prompt, and it should be the first line therapy in the case of anaphylaxis. Along with epinephrine, we could also give fluid resuscitation, in which crystalloid therapy could be given. And we have to monitor fluid resuscitation very carefully. We have to monitor that our patient should also not go into hypervolemia. Along with the epinephrine, these corticosteroids and antihistamines could also be added to the therapy, but make sure that epinephrine should not be replaced by antihistamines or corticosteroids. Antihistamines and corticosteroids are just adjuvant to the primary therapy. The primary therapy will always remain epinephrine, which is given IM to the client. It is always recommended to those persons who are allergic to food or anything else, to keep an EpiPen always with them. In the case of emergency, whenever you feel like that you are allergic to certain and certain thing, and the allergic symptoms have started appearing and they are getting worse, we always recommend the patient to take injection epinephrine immediately. Otherwise it could result in anaphylactic shock, which is a very serious condition. In addition to antihistamine, corticosteroids and epinephrine, we should also consider giving vasopressin to our client if above said things are not able to maintain a required blood pressure, because sometimes a term is used which is called as refractory hypotension. This indicates the condition in which, in spite of giving medications to treat the particular condition, you are doing fluid resuscitation, but the shock is not responding at all. That means your patient's blood pressure is not increasing even if you are doing the fluid resuscitation. In this case, we consider giving vasopressin injections as well. After this acute phase is over and your patient is hemodynamically stable, as a nurse we have to continue monitoring the client for the vital signs, for the respiratory rate, for oxygen saturation, and any deterioration or progression of shock should be informed to the doctor immediately. Now we will move forward to the cardiogenic shock, and let us discuss what it is. Now let us talk about cardiogenic shock. Talking about cardiogenic shock, basically this type of shock occurs when the heart is not able to pump adequate blood according to the body requirements. Hence there will be decreased cardiac output, and the tissues will not get required oxygen, and hence multi-organ failure could occur. Now the causes could be various, like acute myocardial infarction, which is also called as heart attack, and severe heart failure, cardiomyopathy, myocarditis, the valvular diseases and arrhythmias could also lead to decreased cardiac output. Talking about pathophysiology, there will be decreased cardiac output if there is primary defect in the heart. Because of that, if it is not able to pump the adequate blood to the organs will start deteriorating. The compensatory mechanisms will start working in our body, which will initially increase the heart rate and will try to do vasoconstriction in order to increase the BP, but eventually it will result in heart failure. Why? Because our heart is actually using all the energy in that tachycardia. Okay, so it is not able to utilize the energy in proper contraction of the heart, or it is not able to give us the output, and eventually it will lead to the heart failure. Then myocardial ischemia infarction could be there, vasoconstriction will be there initially, but on in the later on condition there will be decreased BP because of the decreased cardiac output. There will be increased cardiac workload which will further deteriorate the situation. So talking about the sign and symptoms, again those 5 signs of shock would be there: altered mental status, decreased urine output, hypotension, tachycardia, weak and feeble pulses, cool and clammy skin would be there, and oliguria would also be there. So if we talk about nursing management, first is obviously assessment. We have to assess the vital signs like blood pressure, pulse, respiratory rate. Also we have to check the oxygen saturation, assess the level of consciousness by using Glasgow Coma scale. We have to see the skin color, temperature and moisture of the skin, and we have to measure the urine output. Remember, urine output is one of the non-invasive and most reliable indicator of shock. Even when we are assessing the shock, it acts as a most reliable indicator, and even when we are relieving the shock, then also it acts as a most reliable indicator. Because if your patient has started giving the urine, passing the urine more than 30 ml per hour, or if it is increased to 50 ml per hour, that means now your patient has started becoming hemodynamically stable. Then we have to give the oxygen therapy as well. Fluid management again with the crystalloids could be done, and we have to give certain medications as well, like vasopressors, like dopamine and norepinephrine to support the blood pressure, and inotropes like dibutamine to improve the myocardial contractility, etc. And we can also give the diuretic. See, fluid resuscitation in this case, sometimes it is not recommended because pulmonary hypertension could have been occurring because the heart is not contracting that much, and it is not giving the output effectively. So eventually the fluid could start pooling into the lungs and it could result in pulmonary hypertension. If that is the case, the doctor could also recommend us to give diuretics to the client. So the therapy is kind of planned in this case according to the situation of the client. If pulmonary hypertension, edema and fluid retention is there, diuretics would be given, and if hypotension is a primary concern, fluid resuscitation could be done, but very carefully. And then intra-aortic balloon pump could be used to kind of improve the cardiac output, or to improve the coronary perfusion. And a nurse should continuously monitor the client during the management and even after the acute phase is over. We have to monitor the hemodynamic parameters like central venous pressure monitoring and pulmonary artery pressure monitoring, and sometimes some invasive monitoring could also be there, like there could be arterial line, pulmonary artery catheter. So we have to continuously monitor our patient for hemodynamic stability. In case any kind of instability occurs, we have to inform the doctor immediately. Okay, so now let us talk about neurogenic shock. Basically, neurogenic shock will occur when there is spinal cord injury. The major reason is a spinal cord injury, otherwise there could be other reasons as well. In neurogenic shock, there is a disruption in the sympathetic nervous system. So sympathetic nervous system is basically not able to do its work. And when sympathetic nervous system is not able to do its work, there will be massive vasodilation, there could be bradycardia and hence shock. The causes could be spinal cord injury, as I have already told you. Whenever there will be injury into the cervical area or in the area above T6 level. So in the thoracic or cervical area, if there is an injury, there could be the high chances of the patient going into neurogenic shock. The second thing is, in the case of spinal anesthesia, when spinal anesthesia is being given, it could lead to neurogenic shock. Then there could be spinal tumors or infections which are interfering with the sympathetic nervous system function and hence leading to neurogenic shock. And last one is a certain medications. For example, if the patient has taken high doses of opioids, or we have given the high doses of opioids, it will interfere into the working of sympathetic nervous system activity and hence neurogenic shock. So the 4 causes are there: spinal cord injury, second one is spinal anesthesia, third one is spinal tumors or infections, and the fourth one is certain medications like opioid overdose. Now coming to the pathophysiology, as I have already told you, in the case of neurogenic shock, there will be loss of sympathetic tone. So sympathetic nervous system is not able to work, and it will lead to decreased tone of the muscles in the blood vessels, hence vasodilation. Also it could cause bradycardia, and due to that bradycardia there will be less cardiac output. Vasodilation will cause sudden drop in the systemic vascular resistance and hence hypotension, and there will be decreased cardiac output as well, leading to hypotension and shock. So the sign and symptoms could be hypotension, bradycardia, warm and dry skin. Now I want to highlight one point: the warm and dry skin is contrary to all the other types of shock in which cool and clammy skin was seen. In this case, because of vasodilation, warm and dry skin would be there. Hypothermia will also be there because of vasodilation, and then altered mental status. If inadequate perfusion is going to the brain, the patient will start losing consciousness. The patient will become more confused. Delirium will be there, and patient will be feeling lethargic. Then there will be the loss of reflexes as well. Usually at the level of injury, if we see, let us suppose your patient is having injury at T6 level. Below T6, your patient will not feel any kind of sensation. So this could also be present in the neurogenic shock. If we talk about nursing management, it's same like other types of shock. Monitoring the vital signs and also neurological assessment, monitoring the patient for the signs of hypoperfusion such as altered mental status and decreased urine output, fluid resuscitation by using crystalloids, but we have to monitor our patient side by side for hypervolemia as well. Then vasopressor therapy like norepinephrine could be given to the client to maintain adequate blood pressure. Spinal cord protection is very important in this case. In any case of spinal cord injury, we should log roll the client. We have to make sure that no part of the body should be twisted or turned, and the client is not allowed to sit, because this could lead to incomplete injury will be turned into the completed one. So no part of the body should be twisted and turned, and the client should be transferred as a unit. Okay. Then we have to monitor the temperature as well, because this kind of injury could also affect the thermoregulation, because sympathetic nervous system is not working properly. So thermoregulation will also be affected. The patient could be in hypothermia or hyperthermia. So this was all about shock and the types of shock. I think you have learned a lot through this video. Well, if you want me to make more videos like this, keep on following Navkiran. You can press the bell icon. You can subscribe my channel for the latest updates on nursing education. Crack your NCLEX RN in your first attempt with Navkiran. See you in the next video. Thank you so much.